Let's start over. Thank you for joining us for today's webinar. My name's Allison, and I'll be kicking things off today. First, housekeeping. All of our participants, and including myself at the beginning of the webinar, are muted, but I will work to make sure that I fix that in the future. If you have questions during the presentation, feel free to put them in the chat. I'll be monitoring that, and I will pose those questions at the end. And if you have questions beyond what we cover in today's webinar, please email solutions@bamboohealth.com, and someone will follow up in the very near future. So a little bit about Bamboo Health. We formed as a new company in August following Appriss Health's acquisition of Patient Ping earlier this year. Appriss Health was well known for delivering cloud-based care coordination software and analytics solutions, primarily focused on prescription drug monitoring and behavioral health and substance use disorder solutions. Patient Ping was known as a care collaboration platform that connected providers to seamlessly coordinate patient care in real time and collaborate on shared patients through a comprehensive suite of solutions. Now we are together as one as Bamboo Health, and we provide one of the largest, most diverse care collaboration networks in the country. Our network enables providers to improve whole person care with a full view of their patient, including physical and behavioral health, all within the clinical workflow. The goal is to improve health outcomes and provide more efficient and effective use of resources. Together as one, we have this mission to enable our customers to optimize value-based outcomes by delivering information, actionable insights, and support for the delivery of whole person care through payer and provider collaboration. And we're happy to have you here with us today. Today, the focus of our webinar is on the Centers for Medicare and Medicaid Services Interoperability and Patient Access Rule electronic event notifications condition of participation that went into effect on May 1st this year. While the name is a mouthful, in short, the rule requires hospitals to send admission, discharge, and transfer notifications to the patient's other care providers, like post-acute and primary care providers. The goal is to promote care coordination in near real time. And while the deadline to comply has passed, many are still figuring out the best ways to adhere to the rules and its implications, especially since the deadline occurred in the midst of the COVID-19 pandemic. Beyond this individual rule, many are stipulating about its future implications and how it may shape interoperability in the healthcare arena. Here to help us sort through all the complexities today is Molly Kane, Bamboo Health's Manager of Government Affairs. Prior to her time at Bamboo, Molly worked in the payer policy at Athena Health, where she led the regulatory review of CMS proposed and final rules and coordinated Athena's operational response to payer and industry changes. Molly holds a degree in government and legal studies from Bowdoin College. So welcome, Molly, and thank you for letting me know that I was still on mute.
Of course, no worries. We've all been there. And thank you, Allison.
And I am about to hand the reins to you. 1 second.
Perfect.
Are you getting a notification to take over, Molly?
Unfortunately, I'm not. And if it's easier as well, and if you'd like to share too, that might be an easier solution since it appears that we might be having a few technical difficulties here. I apologize to everyone. It's one of those days.
Yeah, I'll just advance the slides and you let me know when.
Perfect. Thank you. Great. So thank you to Allison, and hello everyone, and thank you again for joining. And as Allison alluded to, so the goals of today's webinar will be to review the e-notifications hospital condition of participation, or COP, that went into effect this past May, and in particular to really take a closer look at CMS's interpretive guidance related to the COP and how hospitals and health systems can prepare for COP-related audits. And after that, we'll also take a look at what may be next in the industry, particularly with regards to e-notifications and how they fit into a growingly interoperable landscape. And advance the slide, please. Great, thank you. So to get started, just give a little bit of background on the e-notifications rule. So in in March of 2020, two major healthcare IT rules were finalized: the ONC Cures Act final rule and the CMS Interoperability and Patient Access final rule. And while both of these rules contained many final provisions of note, we of course today are going to be focusing on the new hospital condition of participation, which was contained within the CMS Interoperability and Patient Access rule. So this COP joins a number of existing conditions of participation for hospitals participating in Medicare and was added with the overarching goal of improving information sharing. Through this COP, CMS has recognized that patients receive care in many siloed settings and that hospital-related care transitions are really critical moments in which communication and coordination across settings is of paramount importance. And while recognizing that there are existing systems in place for information sharing today through things like real-time notifications, such as admit discharge transfer notifications, CMS really wants, through this new COP, to eliminate any barriers for sharing information, with the ultimate hope and understanding being to improve access to care coordination information, which, as I'm sure we all can appreciate, really is essential to driving improved patient outcomes. And on the CMS side, really looking into cost savings in their value-based programs. Next slide, please. Thank you. All right, so now for a little bit more about the condition of participation itself. So this new COP, or condition of participation, went into effect for hospitals on May 7th, 2021, so this past May, and it requires hospitals to make, as CMS calls it, a reasonable effort to send real-time notifications at the point of inpatient and observation events, as well as at the point of ED events. So looking at observations, admissions, discharges, and transfers. And these notifications are required to go to the patient's established primary care physician, any established primary care entities, as well as patient-identified practitioners or entities, and then finally to any applicable post-acute providers, both patient-identified or currently involved in that patient's care. And then these messages are all required to contain, at minimum, the patient's name, the treating practitioner's name, and the sending institution's name. Although, of course, in many instances, they end up containing more information than that to promote more care coordination. Next slide, please. Great. So in light of this, and with the rule now having come into effect and the condition of participation now being something that hospitals must actually comply with, CMS, shortly after the rule went into effect, so on May 7th of this year, also published its interpretive guidance for this e-notification COP. And this really is meant to give a little bit of additional clarity on some questions that might have come up in the wording of the rule itself, as well as just provide any additional suggestions for how providers and hospitals may consider this rule. And so within the interpretive guidance, CMS actually included guidance for 6 separate provisions within the condition of participation. And 3 of these were really of particular note, and we're going to dive into those a little bit more. So the 3 main takeaways from the interpretive guidance are takeaways around consent language, reasonable effort, and ACO attribution lists. And we will now dive into those a bit more here. So taking a look at each of these 3 components of the interpretive guidance and really what they mean and what they mean for hospitals. So starting at the top here with consent language. CMS included language within the interpretive guidance that created a little bit of confusion around whether the condition of participation for e-notifications requires opt-in versus opt-out patient consent. And this really contrasted with the patient access and interoperability rule itself, which did not create any new privacy requirements and was really in line with many care coordination services' current opt-out models for privacy. So all that being said, and as you can kind of see in the green section here right under it, the interoperability and patient access rule itself really was prescriptive around the fact that entities do not need to obtain any additional or net new consents based on this condition of participation. And while organizations still, of course, need to adhere to patient privacy preferences, this isn't a net new consent process that's being required. And despite the slight amount of confusion with the wording of the interpretive guidance, this intent to solely use existing privacy regulations instead of adding any additional ones was really reinforced in both the rules comments as well as the CMS official FAQs, which both state that if there are any privacy preferences that have already been agreed upon and adhered to by the hospital, you cannot disclose information in breach of those. However, COP does not supersede or add any existing consent requirements from HIPAA to 42 CFR Part 2 to any of an organization's own policies. So really, as long as hospitals are adhering to their own internal privacy policies and practices, as well as to any existing state or federal requirements, they will be in line with the consent requirements for this rule. Now taking a look a bit deeper into the reasonable effort portion of the interpretive guidance. So within the interpretive guidance, CMS strengthened their previous language around hospitals needing to make a reasonable effort to send notifications to applicable providers and entities, to hospitals needing to make, quote, every attempt to send these notifications. And while, of course, this still doesn't give us a perfect definition of what reasonable effort means, it does give us a bit more clarity. And so really, it's requiring hospitals to make every attempt to send these notifications to applicable providers and entities, which at the end of the day means that making a single effort through a single avenue to send notifications will not be sufficient. So hospitals and health systems will need to make a valid attempt to send and deliver notifications, and they may need to actually make multiple attempts to ensure that those notifications are being received and delivered to the entities in question. And this is really particularly important to consider when you're thinking about how organizations intend to provide notifications to certain providers, such as post-acute care facilities that may not have capabilities in place to participate in solutions such as direct messaging. And then finally, we come to the ACO attribution lists. And so CMS included language within the guidance that essentially acknowledged ACO attribution lists, which really can be thought of as eligibility files or rosters attributing different members or patients to an ACO. And they reiterated that nothing in the condition of participation really restricts a hospital's ability to share information in accordance with its current data sharing policies to anyone else who is permitted legally to receive that kind of information. So really, at the end of the day, they acknowledged the existence of ACO attribution lists and stated that there's nothing in the rule that will stop hospitals from sharing with ACO providers via attribution lists, so long as those providers should already have access to that patient information. And really, based on this interpretive guidance and CMS's inclusion of ACO attributions, they've made it clear that they understand that certain organizations use attribution lists and that hospitals are, of course, permitted to share with these organizations. And at the end of the day, it really is clear that CMS is thinking about ACO attribution lists and that there really could very much be a future where we would see sending notifications based on these attribution lists as an additional requirement. So to kind of sum up the key takeaways from the guidance, based on this interpretive guidance, consent requirements are not changing. Reasonable effort really does require an ability to demonstrate making every possible attempt to an applicable entity. And ACO attribution lists may very well be considered for future requirements. Next slide, please. All right, so now switching gears a little bit from the interpretive guidance and looking into kind of what's next now that the e-notifications condition of participation has gone into effect. So now that the condition of participation is active, hospitals and health systems need to really start to begin looking ahead to audits and how to best prepare for these. So compliance with Medicare conditions of participation are evaluated through what we call compliance surveys, which are in turn conducted by either state survey agencies or SAs or accreditation organizations or AOs. And basically, just to give a little bit of a definition around those two items, so SAs or survey agencies are overseen by CMS's regional offices, and SAs have to report their findings and deficiencies to their designated regional office. Whereas on the other hand, AOs or accreditation agencies are organizations that are certified by CMS, and they are organizations by which a hospital may voluntarily elect to be accredited. And when a hospital is accredited by an AO, it exempts that hospital from undergoing routine surveys by SAs. That being said, however, both SAs and AOs conduct COP compliance surveys, but the cadence does differ between the two. Despite the cadence differing, however, it is really important to note that all compliance surveys are unannounced and really can happen at any time. So on the AO side of things, AOs are required to survey a sample of their accredited hospitals as a part of CMS's assessment of the AO's overall performance each year. And then in addition to this, CMS may actually require that a specific hospital accredited through an AO be surveyed at any point, particularly if there are any complaints alleging serious deficiencies. And then on the flip side, for hospitals that are not accredited by an AO, they will be surveyed by SAs every 3 to 4 years approximately. So really, what is being assessed during a survey? And these surveys are meant, of course, to evaluate compliance with all of the conditions of participation for Medicare hospitals for all services, areas, and locations that are covered by the hospital's provider agreement under its CMS certification number, or CCN. And hospitals really operate as one unit for compliance purposes, which is important to note because as a result, any evaluation and certification is provided to all components of the hospital rather than being granted to each individual component. So it really can end up being a bit of an all or nothing score for these hospitals and entities. And so during a survey for the actual procedure, the surveying entity will review the organization's structure and policies, and they'll interview with the head of medical records. And then the surveying entity will also sample a sample size of active and closed medical records for review. And generally, this is 10% of the average daily census and no fewer than 30 records. But then, so once all of this is taken into account and once a survey is completed, what happens next? Next slide, please. So upon completion of an audit survey, the hospital will receive their results and their certification, as well as any citations that may have resulted from the audit. And citations can vary in severity from standard level, in which a hospital is not in compliance with one aspect of a particular condition of participation, to the highest level, which would be immediate jeopardy. And if there are serious deficiencies with one or more of the conditions of participation, so going back to that immediate jeopardy status, the hospital will have 10 days from the receipt of the survey results to complete and submit a corrective action plan. And if the corrective action plan has not been achieved during a reassessment by the surveying agency, which generally happens around the 45-day mark, the hospital's contract will ultimately be terminated approximately 90 days after the initial survey. So non-compliance with COPs, and obviously as a result, termination from Medicare, clearly has substantial consequences. And based on this, it really is important for hospitals to proactively ready themselves for these compliance surveys. So you can see kind of on the right-hand side here, we have a couple of tips with regard specifically to the e-notification condition of participation to help hospitals best prepare for survey success And really, this is by both ensuring that hospitals have easy access to a full audit trail of e-notification receipts, and that these e-notifications are tracked by a unique patient identifier, which will then allow them to easily be able to link back to the patient records that are included within the survey review. Next slide, please. All right, so now that we've kind of thought through COP and what the implications are both for the interpretive guidance as well as for the upcoming audits, it's time to take a little bit of a look ahead and start to think through how e-notifications can really be seen as the starting point on the path to increased interoperability. So as organizations move more towards increasing risk in value-based care models and to a more broadly interoperable healthcare landscape, it really is clear that real-time actionable data for data for care coordination is going to become more important than ever. And we know from this condition of participation, as well as its interpretive guidance, that CMS has clearly begun to think through entities and provider types that are essential for effective whole person care coordination. And the need to share information with an increasing number and type of entities and providers is really only going to expand over time, which is something that CMS clearly acknowledges. So in the future, iterations of similar e-notification requirements could very well include ACOs through their attribution lists, as well as have a renewed focus on other settings and types of care, such as things like home health and behavioral health, which we've seen really take a center stage as of late, particularly with the COVID-19 pandemic. And as we know, rules passed through CMS can also really be indicative of coming change further down the stream, with state Medicaids and other regional players oftentimes building upon CMS's requirements. And I will say that this certainly appears to be the case with what we've seen so far for e-notifications, with a growing number of states and other entities identifying them as obviously critical for effective care coordination, particularly for vulnerable populations. And so based on this, we very may well see an increase in similar requirements to that of the e-notifications condition of participation on both state and regional levels. Next slide, please. All right, so as we can see, there's obviously a lot of change, both with regard to interoperability in the industry, as well as to how it relates to strategies for effective value-based care and care coordination. So really taking a step back, let's think about what this means for organizations across the care continuum. And ultimately, value-based care and interoperability really are two parts of the same equation. So as the industry moves forward with these increased efforts towards interoperability, this in turn will ultimately push for an increase in value-based care and vice versa. And while we know that there's a lot changing within the overall healthcare landscape today, through the condition of participation, its interpretive guidance, and upcoming changes to value-based care programs, as well as other rulemaking, CMS clearly recognizes that timely, actionable information on patients is a critical component of an interoperable system. And with that, we have wrapped up the presentation portion of today's webinar, and I will hand it back to Allison for questions.
Thank you, Molly. Much appreciated. If you have a question for Molly, feel free to put it in the chat. I'm going to take a quick look and see if anything's in there. I don't see one yet, but I'll pose a question in case some folks are formulating theirs that they want to submit. So you kind of ended with this, Molly, with value-based care, and that's kind of what I call a buzz phrase that we've been hearing in healthcare for probably a couple of decades, actually, but it's really, really challenging to implement. So how are rules like this kind of helping that momentum forward?
Yeah, absolutely. And I think we certainly have all felt the pain of the slowness of implementing, changes to the healthcare system overall, and value-based care really is no exception to that. But one of the things that I find exciting about rules like this and about the info blocking rule and all of these other rules focused on interoperability that are coming out of CMS and other agencies really is the fact that it's acknowledging that technology and some of the information that we have today through technology is so critical for properly coordinating patient care. And I think that that really does tie in hand with value-based care, where if providers aren't able to have access to timely, actionable, and important information on their patients, they're never really going to succeed in a value-based care model. And so my hope, and I'm assuming the hope of this administration really, is to enable providers and different entities across the care continuum with some of these technology resources that we already have in place today. And as a result, potentially make the transition to value-based care be a little more seamless and hopefully pick up the pace a little bit more.
Great. We got this question in. Does an individual patient have the right to see if the COP has been accomplished?
Sure. And so for that, I'm going to guess that the question means, does an individual patient, oh, okay. So I'm thinking through the two aspects being, if you're referring to like if an individual patient is able to see whether or not their information has been sent based on the condition of participation, or conversely, if they're able to see a hospital's results based on each condition of participation. And so starting with the first, unless there's any clarification that's been included, I can answer both of them. And so starting with the first option, individual patients won't be able to see the discrete messages or the individual messages that are sent on their care events to their different providers as a result of the condition of participation. That being said, patients are always able to opt out of these types of situations and care coordination events. And so for that, I would certainly suggest reaching out either to your hospital's administration or to any of the care coordination companies or services that you may utilize to determine what the best route may be for opt-out policies. And then on the flip side of that, for anything related to whether or not you'd be able to see an individual hospital's results for each of the COPs, unfortunately, typically that information is not broadly published unless the hospital has had severe deficiencies within one or more of the COPs. And when that is the case, CMS may decide to move forward with publicly publishing the results for any hospitals that have deficiencies. But unfortunately, you aren't able to, at an overarching level, take a look into the data and kind of see performance across all facilities.
Great, thank you. Couple more came in. One is it anticipated that patients will experience a change in transitional care, and will it be apparent?
Yeah, that's a great question. And I'd say we still certainly have to wait and see on that for a bit, but my anticipation, and I think the hope and intent of CMS would be that there would be a noticeable improvement of transitions of care. So thinking through, you know, if a patient is discharged from a hospital, are they going to hear from their PCP, or are they going to need to reach out to their PCP to coordinate any follow-up care? Situations like that, I would kind of fathom being the ones that would be most noticeable to patients, where they might start seeing kind of more proactive outreach and care coordination from their care team.
Great. Another question says, is this a one-time ask, or does it need to be asked at each admission?
Yeah, so the condition of participation requires it for each individual admission, as well as any subsequent transfers or discharges that follow that admission. So it'll be a continuous kind of ask and solution that is required for all hospitals.
And one more, other than audits, how will the rule be enforced?
Yeah, so audits really are the primary lever that CMS has for enforcement of their conditions of participation. That being said, however, the kind of consequences of a failed audit for any condition of participation, including the e-notification COP, are pretty substantial. So hospitals, if they fail to comply with the condition of participation, ultimately risk losing their contract with Medicare, and then, consequentially could also risk losing contracts with their state Medicaids, both of which would put quite a dent into a hospital's revenue.
Great. And the final question is one that I can answer. It asks if we'll be emailing out the slide deck, and you will receive a follow-up email from us with the recording of the webinar. We'll also include a link to a copy of our 4-book ebook series about the rule and its implications, and that fourth one is what we really based most of Molly's presentation on today. She was a huge help in making that ebook a reality, so that could be a valuable resource for you. I don't see any other questions, but if anything comes up later, you're welcome to email this email that you see here, solutions@bamboohealth.com. And thank you all so much for coming, and thank you, Molly, for your expertise today.
Of course. Thank you so much.